Very good afternoon to all. Welcome to this session welcome to this Samvad session. It is my proud privilege to introduce Professor Srikanth, the esteemed speaker of today's Samvad session. Professor Srikanth is a professor of practice at IIIT-Bangalore and the co-convener of the EHRC Center at IIIT. I have had the privilege of collaborating with Professor Srikanth, and in my interactions with him, his conviction and passion for making impactful contributions at scale were unrelenting. Every time I speak, he was very clearly of the conviction that we need to make large programs which are impactful. That is something which is very strong in him. And the public health delivery solution, the DMHP program, known as EHRC, was a great success in Karnataka. Actually, the DMHP program was a great success. And it was seamlessly scaled up to the nationwide Tele MANAS program. We all know about it, which as of today I checked, it has received more than 1.2 million calls across the country. Among its many achievements, this helpline, I would want to specify, plays a crucial role in supporting individuals during crisis moments, preventing self-harm, and several hundreds of lives are saved every day. The distress calls. So it is really something which gives us goosebumps, which we have to be really proud of what Professor Srikanth has really achieved. You will hear more about this in the talk. He has a wide range of research interests that includes mobile and internet-based applications, e-health, health information systems, data privacy, computer graphics, and geometric modeling. Prior to joining IIIT-B, he had over 28 years of experience in the software industry. He has done multitude of roles. He was earlier at Saskin Communication Technologies, where he handled business, technology, and product management roles. And he has led various product and R&D initiatives, especially around wireless and multimedia technologies. Earlier, he co-founded and led software development for a startup in the US, focusing on geometric modeling with applications in mechanical design and geosciences. You speak graphics, you speak software development, you speak IT. He's the man to go to. Dr. Srikanth obtained his PhD in computer science from Cornell University and a BTech from the Indian Institute of Technology, Madras. About this talk, in this talk, Professor Srikanth will speak about EHRC, the flagship program at IIIT-B, which conducts interdisciplinary applied research on technology-enabled solutions to address the healthcare needs of the underserved and marginal population groups. That is the primary objective of this program, with an objective of improving affordability, accessibility, and availability of healthcare services. He will dwell into the center's research, which is broadly centered around medical devices, health data, and healthcare delivery systems, with particular application in the area of mental health, malnutrition, and disabilities. Professor Srikanth will also highlight the collaborative projects working with medical research institutions and hospitals, as well as government departments. Further, Professor Srikanth will look at the context and relevance of technology-based healthcare solutions, especially in public health in India, an overview of the research at HRC and opportunities and challenges in this area of work. We will also briefly discuss some of the recent and ongoing research in EHRC. Over to you, Professor Srikanth. We look forward to your talk.
First, thanks to Professor Ramesh for that warm, kind introduction. It's wonderful to again have a chance to present the kind of work we've been doing here to this group. What I'll do, voice is a little off. Hopefully, it'll come back to normal as I talk. What I'll do is, broadly, we're going to look at healthcare services in India, mostly in the Indian context, and look at how basically technology can help and where we are trying to contribute and make a difference here. So I'll talk in the context of the work that's going on at the eHealth Research Center here. I will, as I go along, also talk about what the center is about, what we do, and the kinds, just get a flavor of the kind of projects that we are doing here. So maybe first few minutes, we'll talk about healthcare in general, healthcare in India, and the peculiar and the challenges that come up there. And because one of the key things that was sort of driving the work at EHRC is to look at research, but also look at research that would actually get applied, translational research, And so it's important to understand the context of healthcare, and there are lots of technology you can do, but what of it can actually potentially get used in the field is of great importance. So I think that's also a perspective we've been trying to have throughout our work here. So what is healthcare? Anything and everything. Healthcare is a vast subject. Almost anything related to human health will be called healthcare. And we can start off by taking a very simplistic view of it. There are patients, and there are patients, and there are medical professionals, doctors, hospitals, clinics, and so on. And when we need help, we go and reach out to these people. And typically, the default option is you walk into a clinic or a healthcare facility and get something done. And the only challenge here is the scale, right? I mean, this is not a small number. It's whatever, close to 1.5 billion people spread across India. If you take India and through anywhere else, I'm using India just as a context. You can scale it up or down as needed. And it is healthcare is something that needs to touch almost everybody. Almost everybody at some point in their life will need access to healthcare. There are some specialist doctors of various kinds available in various places. And part of the problem is these two don't match, right? The doctors are somewhere else, the patients are spread, or the potential patients are spread out all over the place. So the healthcare system tries to, arrange itself in a way that can deliver this care better. So it's not enough if doctors are available in the clinics. We increasingly have community health services where actually either doctors or various kinds of health workers are closer to where the patients are. Could be in villages, could be in taluka office centers, district hospitals, and so on. And these are not necessarily doctors, but they represent the medical activities, services, and they deliver it closer to the doorstep. And we hope that the healthcare workers and the doctors are somehow connected. Information is flowing between them, and they're able to together provide care to the families all over the place. Right? This is sort of a very simplified and maybe obvious way of looking at it. But this needs some structure. So if you look at a healthcare service in India, a large part of the healthcare is delivered by the government organizations, what's broadly called the public health services. And that itself is a very complex structure. There's a sort of a pyramidal structure that's been set up with specialists at the top and what are called sub-health centers, or now what are called health and wellness centers, much closer to where the people are. As you can see, there's one HWC for every 3,000 to 5,000 population, at least by plan. And these will be, the upper part would be typically at district hospitals, large towns, and so on. And there's a range of different kinds of centers. So starting from the apex till about the primary health centers, you have actual doctors, MBBS professionals who are available. At the sub-health centers or HWCs and below, you might not have MBBS doctors, but you will have trained nurses, ASHA workers, ANMs, community health workers, and so on, who actually reach out to the people. And it's important to understand this whole thing. Typically we think of going to a doctor, getting a treatment, and coming back, but there's actually a whole system that has to mesh together. And so this is the government system in India. And just to get an idea of scale, if you talk about district hospitals, there are roughly 700 districts in the country, so roughly one per district. And there may be a few more. So we're talking about order 1,000 hospitals, 1,000 to 2,000 hospitals at this level. The primary health centers, any idea how many there are in the country? Roughly. You can actually do the division quickly and see, but there are about 25,000. It should be closer to 50,000 as per the plan, but there are about 25,000 that are operational. And when you get down to health and wellness centers, there are 150,000, 1.5 lakh such centers. You can imagine the scale of operations we're talking about. And we say, okay, vaccination has to be done in every part of the country. It has to actually get connected to this huge network of healthcare delivery people that are there. So this adds to the challenge. There's a challenge of scale. Right? Anything that we talk about, if you really want to do it at a national level, you have to deal with lakhs of touch points, billions of people, thousands of doctors, lakhs of touch points. So this is the good part, right? I mean, at least we know what the problem is. While this is what is needed, we are, so it's impossible in the current situation for doctors and other professionals to actually be available at your doorstep or close to your doorstep. So with the advent of technology, another important leg that's being added to this is telehealth services. How do we get services that can be accessed remotely? And there can be different kinds of services we talk about. That adds to the ability to deliver. It makes it easier for patients and caregivers to access health, and it improves the efficiency of the system overall and something. But very fact that it's telehealth means it's heavily hinged on technology being available. This has been made possible only because communication systems are much better than they were many years back. Okay, so this is what we have. But while this is a nice picture and this is sort of the plan that's there, in practice there are a lot of issues. So we'll just look at some high-level challenges that are there. The most important one probably is that there is a desperate shortage of doctors. So there's a severe shortage of doctors. Even the best case estimate is there are around 5 per 10,000. There are no clear estimates on how many registered doctors there because there's no real system to connect all these. The best estimate is by 2020 we'll have about 8 per 10,000, maybe 11 if you count many of them are not practicing, migrated and so on. But the need is somewhere around 20. So even the best case, we're off by a factor of 2. And the problem also is it's skewed towards urban areas. So if roughly 2/3 of the population is in the rural areas, roughly 2/3 of the healthcare professionals are in the urban areas. So again, you can see the ratios get skewed quite a bit. And these are talking about doctors. When you start talking about specialists, pretty much any specialization is way below this, right? There are a few thousand cardiologists in the country. There are about 1,000 psychiatrists or 2,000, I don't remember the exact, 2,000 or 3,000 psychiatrists, 1,000 clinical psychologists and so on. That's all for a country of this size. So this is a problem that's not going to go away, right? Even with all the effort, these numbers are only creeping upward. So you're always going to have a shortage of doctors, always going to have a shortage of nurses. Even nurses, I think the ratio that's there is roughly half what WHO recommends. So pretty much across the professional spectrum, there's a shortage, perennial shortage. Non-communicable diseases are increasing. Maybe infectious disease and others are controlled better, but hypertension, diabetes, cancer, mental health, all these are increasing. And a lot of these are chronic things that need extended care. So we need access to doctors on an ongoing basis. And because the doctors or the facilities are not where the patients are, patients typically have to, the large number of patients travel to see the doctors. They have to go out of their town, out of their village, out of their district, and typically with their families, spending 2-3 days for a 5-minute appointment, and you can imagine the economic and social cost of that. So this is a huge problem. And because the hospitals are not staffed properly or the skills are not very good, everybody ends up going to the tertiary hospitals, district hospitals, specialist hospitals, and so on. So here there's a huge overload in the tertiary hospitals. AIIMS Delhi sees 9,000 patients a day or some number like that, right? NIMHANS sees over 500 mental health patients a day. So you can see the scale that's there. And apart from the load, the hospitals are not set up to handle this. So there is doctors are fatigued, there's risk of errors, which is probably what they're more worried about because they get minutes or seconds per patient sometimes. So all these are, sort of the background we should have in mind saying, where are the problem areas that we can look at? How can we look at technology solutions that will improve? You can't touch all of this, but maybe, make small dents here and there. So pretty much anybody you talk to, you ask about what you need to do about healthcare, they would say, these 3 words, right? You improve accessibility, availability, and affordability of healthcare service while maintaining quality. Yeah. Yeah, so you can do something similar for the private clinics. They're also as skewed, probably even more skewed. So like I said, roughly, I don't remember the number, somewhere between 2/3 to 3/4 of the healthcare that's done is done by the government clinics. Interactions at a total level, roughly. So yeah, they play an important part. So you can mirror this, in fact, it'll be similar. I mean, in fact, in private clinics, you'll have even less specialists in rural areas. For instance, it's happening?
In education, is there a sort of widespread mistrust against government healthcare facilities and people gravitating towards private clinics and so on and so forth?
Yeah, so you're saying, is there a mistrust in government hospitals that's pushing people more toward? I'm sure that's there, but there's still enough load on the government hospitals. It's not that they are underused. I think a lot of people don't have the choice of going to a private clinic, right? The other thing in healthcare is there's a lot of these informal treatment things also, right? It's not formal healthcare, faith healers, whatever, right? So between all of them, but I think my one is between, I don't remember them, 60% or so of the healthcare services are delivered by government institutes, somewhere in that range. And it's a large percentage, right? I mean, anyway, I'm not trying to focus on I'm just giving that as an example of where there's some structure that we know and the challenges that are there. Everything here would be relevant everywhere else also, right? So therefore, I think this is what people always talk about. How do you make, how do you get services available where the people are? If they're available, how do you make it accessible to a wide range of demographics of people? How do you manage affordability? Healthcare, bad health condition can make a family bankrupt or push them into poverty. And of course, we need to improve quality of care. It's not great at all places. Now, when you talk about the public health, I think we focus more on these three, and affordability in some sense the government takes. I mean, affordability of scale brings in some advantages. We can keep even assuming we ignore this, the other three become very important, right? And if you look at the macro picture, I think there's a focus on rural areas. We need to solve that problem. It's really pathetic, the gap between the urban and rural areas. And all public health experts say start with the primary care. If you can improve the quality of primary care, you can solve many of these problems because the load on the tertiary care will go down, people's health conditions will be better, and so on. So these are just, if you had to focus, you could focus here, but you could do in other places also. It doesn't matter, right? So, I mean, my personal thing is that this is where these two are where you should really focus if you want to make a big scale impact. And that, I'm talking about at a major level, not at our level. So that's what we want to do. Yeah, so there are many expectations of what technology can do, and we can also, understanding technology, we can say, yeah, these are things that can be done. Can technology be used to improve skills and capabilities of doctors, especially primary care doctors? There's a great book called Digital Nation written by N. Chandrasekhar and Rupa Purushottam, which talks about where AI, I guess technology in general can help healthcare. And what they very clearly show is if you can improve primary healthcare using technology, and there are opportunities for that, you can help the system quite a bit. If nothing else, improve medical training. The doctors have to go through rigorous training, and you can imagine that medical training is very people intensive, resources intensive. Can we use technology to improve that? Virtual learning of various kinds and so on. This is probably something that if you look at a national strategic level, this is what there is a lot of focus. How do you improve services closer to the home? You basically reduce the need for people to travel one way or the other. That improves lots of things. So it could be clinical, of course. It could also be diagnostic. So increasingly, you'll find that in Karnataka, at least, a lot of districts and smaller hospitals have X-ray machines. Every public health center is going to have a blood analyzer machine. Okay, and so on. So we're talking about large scale thing. And also remote therapy. You don't need to go to a hospital to get therapy once you've been diagnosed and there's a follow-up to be done. Part of this would also be start early. Can we do screening better? Can we catch diseases earlier? Can we catch conditions earlier through better screening? And intuitively, technology can help in many of these things, right? One big need is to manage patient data. By definition, all of us, by its very nature, all of us will, over our lifetime, see many doctors, many hospitals, in many cities probably, many locations. And ideally, this data should all be available, integrated for me to get the best care. And in practice, that we are far from that. Again, we rely on piece of paper or very fragmented systems, data sitting in silos. So longitudinal data management is needed, especially to manage chronic conditions. If somebody has diabetes or hypertension, which is long period, the doctor needs to know how the person has reacted to different medications and dosages over time. It's not enough to look at the last 2-3 months of data. And by having the data available is what's called continuity of care. People are mobile, they move across various kinds of setups. Can we still ensure that the care they get is a continuum? And for that, access to complete integrated data is needed. And data is there sometimes. Increasingly, our data is in various places, but are they integrated? They're not. It's very difficult to access it across the entire range of hospitals. And there are initiatives to improve that. The Ayushman Bharat Digital Mission is a national network for connecting all health facilities so that data can be transmitted easily. But with the increased availability of data, you have a higher risk of privacy. So we have to do all this while ensuring privacy also. I don't want my health data to be easily available by anyone except with my permission, right? That's very clear. And now with laws and other things that are there, this becomes even more. So this becomes a big issue in managing health data. And doing some of these will hopefully reduce the load on tertiary care hospitals and so on. It is important to, pretty much every doctor, every specialist you talk to says that, depending on the doctor you talk to, 60, 70, 80, 90% of the patients I see do not need to come and see me, especially for follow-ups. Starting with cardiac surgery to brain surgery to other things, they said most of this can be managed remotely, but almost never practiced. People, you go for a follow-up, spend 2 minutes and come back, right? And can we improve the ability of doctors to make decisions, write prescriptions by well-designed clinical decision support systems, which will improve the quality of care because now we have more access to the personal information and provide better personalized care, right? So these are some, there are many more, I just picked a few. So this gives an idea of saying, yes, there are lots of places where technology can help, lots of ways in which it can help, and we can therefore start looking for problems for which we might have solutions in those spaces, right? Rather than starting with a solution and looking for the problem, there are problems that are already identified. So if you go back to our picture, there are lots of technology-based solutions that are available. So just give an example, health information systems are critical to manage and collect the data, diagnostic systems, therapy systems, clinical decision support systems that will help the doctor, analysis of data, both for research and administration, policy making, medical research itself, which is going to feed into all these things in a little later, and training. All these are happening and need to happen at the more on the doctor side or the hospital side of things. Of course, there's a lot more that can be done on the patient or the people side of things. So again, examples, you have point of care devices that the health workers could carry it around, the patient portals with health help, tools, applications, remote monitoring, remote therapy, and various kinds of tele-ICU, tele-radiology, tele-pathology, all of these are happening right now in some fact. And every one of this is happening even in the public health system. Government of Karnataka runs tele-ICU units. They have tele-radiology, they have tele-pathology and all these things, right? And so the doctors are sitting somewhere else and monitoring the ICU, the specialists, the intensivists, the interventionists. They cannot have a specialist in every ICU in the country. So you actually have hubs where a small number of doctors are monitoring beds. And the people in the hospitals are the regular doctors. And that was, in COVID, that was used a lot, and now that's being continued in some places. Right? Infrastructure to some extent. By the way, this is not a new thing. 15 years back, doctors sitting in Chennai were monitoring ICU beds in the US. 15, 20 years back, with dedicated video lines and all that. So it's been going on for a while. You can think about the problem while we're talking about India, to look at rural America. They have good hospitals, but no doctors. The problems are similar. So what they did, because was to set up these ICUs, which are rigged up with cameras and sensors and all that. And board-certified doctors sitting in Chennai were monitoring it. And so this is not new, like 18 years, 20. I saw this 15 years back. So there's a lot of such things that can happen. So every one of these is a place where technology fits in and is being used to do some part of it. So in a way, we have a large playing field. We can pick and choose a part of the playing field depending on what technology we are interested in. What is important again is that any technology solution we come up with has to integrate into the healthcare system that's there to some extent. We cannot, given the scale, it's very difficult to come up with something completely different. So the healthcare system, therefore, I'll use, I think it's most stark in India. It's probably true in most places. We have a complexity of scale, just given the number of people, number of entities, number of health facilities, and so on. We have a complexity of a variety of diseases. Every disease is somewhat different. Every treatment plan is somewhat different. Well, you can have a broad framework within which they work. There is specificity and specialization needed. And you have the complexity of demographics and geography, right? Every demographic group needs a little different way to do it. You cannot expect certain people to travel very far. You cannot people need to interact in their local languages, all kinds of other things are there. Right? So while these are all possible, every one of these solutions needs careful engineering and tweaking to get it to fit exactly into the system. So while there are lots of these systems, not all of them are successful, but I think together they are making a difference. So which is where that gives the backdrop on which I think EHRC has evolved over time to work in this space. So this was a research center set up exactly 9 years back. In fact, September 15th will be our 9th anniversary. And we hope to have a series of things to celebrate the 10th year of EHRC. Kicked off on September 15th. We are still trying to plan it out, and we'll come to you, Professor Das, for that. So it's a setup. And this slide, by the way, is almost what it was 9 years back. That's the good news. Okay. Strategy is often hindsight, they say, in marketing and all that. For us, strategy is hindsight, but we set up this thing and we more or less, things happen that way. So it's an interdisciplinary center for applied research in the technologies we have done. And we try to give it a focus on, we'll look for opportunities in underserved communities, underserved areas, and so on. And ultimate goal has to be to improve affordability, accessibility, availability. And given our technology focus, our technology background, we said we'll look at 3 aspects of health services: medical devices, medical data, and delivery of medical health systems. And I think we can force fit almost everything we do into one of these 3. Right? It's a little effort. And as part of this, we also want to contribute to not just the healthcare service, but also policy, capacity building, and all these other things. And right in the beginning, we picked 3 areas as areas of focus without actually having a very strong basis for doing that. Again, those turned out to be reasonably good. Mental health is where, by chance, by work, by a combination of everything, is where most of our focus has been. And malnutrition and disabilities also, I'll talk along as we go. And we've been fortunate in this time to work to build up a large network of partners, collaborators, funding organizations, so on. NIMHANS has been our biggest partner, and through them, we've been working with both the Karnataka Department of Health as well as the Central Health Ministry, Bangalore Medical College through one of our projects, and so on. We get funding from various organizations, some from the government, but also as part of projects of ICMR, technology innovation hubs, and some of the companies like, again, some of these have come, like the Microsoft Philanthropies has come along with NIMHANS, IBM, Sony, and all are given faculty research type grants. And we work with a number of startups, industry things, both on as part of in the research stage, as well as they are our partners for software and other things. Feldspar, Hyperreality is incubated here. There's a project I'll talk about, and other companies that are helping us in the software development or other aspects. Vision Empire also is an entity that was incubated here in the disability space. Okay. So right now, I apologize up front if I left out some key names from here, but Mr. Jaya, Amit, Madhav, and I kind of overall run this organization. We recently had Akash Narayana join us. He is sitting here. You can just raise your hand for them. He has joined us as technology manager for the AI projects in EHRC, and is sort of funded by MINRO. So it's a MINRO. So we have decided earlier this year, thanks to Professor RC, that MINRO and EHRC will work together on the AI in healthcare topics. And Akash is coming from that perspective. We have a number of faculty who I've put the ones who are currently engaged. There are a few others who might have dropped out. So Dinesh, Dr. Ramesh was here, Dr. Sushri, Dr. Raghuram, and Dr. Tulika, who joined more recently, have all become enthusiastic participants in healthcare projects. So we look forward to more people joining and also more work from them. And of course, there's a large pool of students, researchers, projects. Actually, the last 2 teams here, rows here, are EHRC project staff, plus a few more at the back. So the crowd here is already, we pre-filled the room with that. And through these faculty, we collaborate with a lot of the other labs that are here. And want to again emphasize the partnership with NIMHANS, which started right after we inaugurated. So from January 2016, so it's the 8th, 9th year that we are doing this. And it's been an amazing partnership that's led to most of the projects that we will see in that. So here, it works out well because it's a good collaboration between the medical experts who have ideas and want something solved. And we have the technology experts who are looking for problems and are willing to work with them, then that's a great combination that, you can really achieve a lot of stuff. So we will look at some examples of that. So we will, yeah. In India, not much.
I mean, you say technologies do something, doctors want to do something, but then they all have, ultimately something has to be certified, right?
No.
In order for something to become routine care.
So it's certified typically through a medical validation process. So there'll be some starting from the ethics boards of the hospitals and working your way up. So the government, if it's going to adopt some of this, will get it validated by some set of experts. There's no formal certification process.
No.
Yeah. Question. But given to the biomedical instrumentation where your lot of testings and those that goes inside the body and all. So that goes through a lot of certification testings like your angioplast, all those kind of things. But these kind of our work, which is happening mostly on applications development and some of those to helping the existing systems, like they have already database designs, application development and all, where this kind of regulatory doesn't have much touch in that. However, regulatory will come in the higher level, which Professor Srikanth just now said, when the privacy of the data, policies of the data of the hospitals and all, those things will come up, but that will be in the medical level and all. As we are concerned from IIIT point of view, our works are mostly in a software levels or the applications levels and all. So anyway, that is not yet touched by the regulatory in that sense.
Yeah,
What you said, Professor Srikanth, may I add something?
please.
So about 2 years back, 1 or 2 years back, Professor Sridhar and I worked along with a PhD student on a particular problem of formally verifying regulatory compliance of vaccination portal. It was actually an already developed vaccination portal, and regulations were evolving very quickly, and the makers of that portal were concerned about whether we are catching up with the regulations or not. So we were trying to formally verify their algorithms and stuff like that, and we did actually find that there are possibly some non-compliances. Yeah.
So I think so there are very specific, so nowadays there is a privacy, the DPDP Act requires certain compliance, the security requirements. So there are very specific things, but I think some body like ICMR or the DGC, drug control, they have to authorize it at some level. But devices are very different, but even there, I think as far as I know in India, there's no equivalent of FDA approval. So we'll go through quickly sort of the range of projects. We'll start with, yeah.
People are talking about is that reach any level of maturity?
UHI, yeah.
If that is there, then I'm sure you would have a lot of touch points with that, right?
Yeah, so UHI is still a little away. It's still in draft stage. It's going through, so the ABDM is the backbone for that. The Ayushman Bharat Digital Mission is the first step in that, which provides a backbone in which everybody can connect and share data consistently. Interoperability of data is the focus there, under consent, under control of the patient. So the idea is that is once everybody is connected, wherever whichever hospital or lab your your records may be in, you can go to another hospital and say, please go ahead and access my data, ask that data, that hospital to share my data, and they will share it with this hospital. So it's more about sharing of medical data under control of the, so that's still happening very slowly. The next step is in parallel. Now you think of this layer, there's the underlying data connection layer. On top of that, a bunch of APIs that will allow querying for services available, who wants to offer what service. And then the UHI would, the equivalent of UPI, would provide a universal health interface that can allow applications to be developed. So I think that's still a little time away. I haven't seen major movement in that. Medical devices, yes.
Everything is covered by the same drug controller.
Yeah.
Controlling the devices. You're right, there's nothing like a fee.
You know, yeah, but yeah, that's what I said. DGC approval is finally what you have to get for these things. Okay, so we'll talk again in the context of data, devices, and delivery. I'll start with the health data, and I would request Professor Jaya to come and talk about her part of the projects here, the work here.
So this is a quick overview of the kind of work we are doing at EHRC and GVCL lab. So we are looking at population survey data. Now, the reason why we thought population survey data is a very important topic to work on is because a large amount of the data collection activity that happens in the healthcare space, of course, a lot of it comes from the hospital because data is collected there. But a huge or a predominant part comes from collecting it through surveys, right? So when we talk of public health and public healthcare and the programs that the government doles out, a good way to check how those programs are working or not working is essentially assessed through through population health surveys. And the other part is, okay, we talked a lot about going to the hospital and getting treated, but looking at things like how do you come up with the indicators, right? Indicators that are required for WHO or any of the UN agencies, or now we are looking at SDGs, right? Sustainable Development Goals and all of that. How do you get data for all of that? All of them come from the population health surveys. Right. So here the focus is largely on population health surveys. So we have looked at the different aspects of what happens during a survey. So there is this part of survey design that has been around for a very, very long time. And then there is the part about respondent data analysis. So the survey, the data that is collected for every question what a person answers is you get a large tabular data set, and then you can do a whole bunch of analysis of that. Then the parts that don't get so much love is really the questionnaire, right? There are things that around the questionnaire-centric analysis one can do. And the last part is where the respondents are involved. So you could look at how the respondent behavior is and study that part as well. So in our work, we have looked at respondent data analysis. In general, a lot of the data analysis is based on just statistical analysis and a whole bunch of spatial analysis for maps and things like that. So what we have done is we have looked at understudied problems and checked if we could make a difference there. The next one is a question-centric analysis, and this was an interesting problem that sort of came out of my PhD students' work, and actually her DAC members had suggested this problem. So the idea here is that when you have multiple population surveys, right? And you have surveys that are conducted at very large scale at a very high economic cost, right? One would think like, why don't they just do all of them together? But usually that is not what the case is, because these surveys are done for certain purposes by certain agencies, right? But then the data is there. So can you make sense of the data together, right? So that was something that we looked at. So the idea there is like, can we look at questions across two different surveys and see if we can merge their answers together to make sense of multiple surveys together. So that was one work there. So initially we did the brute force method by which we evaluated the questionnaires and checked, if there are outcomes, as in health outcomes versus factors that affect a certain outcome. Can we merge those questions together? And then later on, we used natural language processing on these questionnaires to check if we can automatically find these question pairs across two surveys. Then the last one is a respondent behavior analysis. So that kind of came from the way NFHS, that is the National Family Health Survey, is conducted. It is conducted as an interviewer-based method, interviewer-administered surveys. So there's an interviewer that goes to each household and collects data, right? So then COVID hit, and then we were like, why is this not done online, right? So the general perspective in this particular domain is that if it is a self-done surveys, there are problems of non-responses. which these are again there in the literature for a very long time. There are non-responses, and there are also part where the respondent gets fatigued and then they answer wrong things, right? So the idea was to see if such data collection gathers data very faithfully, right? So can we then estimate when is that respondent gets fatigued, and when is that they start answering or stop answering, right? So that is essentially what we are doing there using gaze tracking, where we are doing it for online surveys. So these are some of the results that we have. So these are the questions we merged from NFHS 4, that's National Family Health Survey, the 4th edition, that is 2015-16. We look for another survey that was also conducted, which is a comprehensive national nutrition survey. Now, CNNS was done especially for children from 0 to 18 years of age, and NFHS 4 was done at the household level. So what we then did was we looked at micronutrient deficiencies from CNNS and mapped it to contextual factors from NFHS, which looked at economic factors, social factors, etc. Right? So say, for instance, we look at the image here, that is vitamin B12 deficiency versus low women BMI. Now, low women BMI is also considered for maternal health conditions when, this particular analysis was done for children below the age of 5. So what we see is in these states which are shown in red, they are hotspots, as in both these factors are low, as in it's low vitamin B12, as in high deficiency, and low women BMI. So we are able to make these kind of analysis using 2 surveys together. So this is another thing that we did. So even from a single survey, can we look at 2 outcomes at the same time? So here we looked at different malnutrition conditions. So there are 5 such conditions, 3 undernourishment and 2 overnourishment. And we looked at how in different parts of Karnataka, there are these co-occurring. So this is an analysis we did using visualization and statistical methods. So yeah, please.
I just want to ask, most of the surveys are basically door-to-door surveys, right?
Yes.
So assumption is ASHA workers would be feeding the information.
No. So these national family health surveys are usually done by school teachers, just like census is done. It's not necessarily ASHA.
Specifically hired for this.
Okay, thank you. That helps, because I was just wondering what is the validity of the persons filling the data
So
itself?
usually that is to make sure literacy part is also covered.
Okay, thanks.
Thank you. Yeah.
Thank you. Okay, so that was one type. We'll jump to another one, context of medical imaging. So basically we look at analysis of different kinds of medical data and pick one that's not so common, which is pathology slides. So basically pathology slides are these biopsy slides that are made, put on a glass, and then viewed under a microscope by pathologists. This is slightly different because they're very high resolution images, 20x and 40x. We have anywhere from 40K by 40K pixels or 60K by 60K pixels. So we're talking about images which are very large and which have very fine detail in them. And the goal is to see if we can pick out certain pathology conditions out of this and help the pathologists do their job better, right? So this is something we've been doing for a few years. Ramesh, who's here, has been working with me and Ramesh have been working with doctors in NIMHANS. They've been very helpful in this, and we have had a bunch of MS students who have been doing some work in this, and we're now trying to ramp up this. So the basic idea is a pathologist sits down with a special software, and they mark these regions saying this is necrosis, this is something else, and so on. And then from this can we automate the analysis of these slides. So if you feed a new slide, it'll be able to find out these regions of a particular pathology. It has its own challenges. Every modality has its own challenges. This has its own challenges. And we were able to make some headway, at least for the simplest problems, which is the detection of necrosis. Necrosis is for the late stage in tumor where the cells are essentially dead, right? And finding that helps the pathologist speed up their whole operation. And also, so we were able to, one of our students here, Nagaraju, who just graduated this year, built a deep learning network using not just basically I do some work to figure out essentially what was the best way to build the model so that it could pick out these things, because these features turn out to be micro features and not macro features. So if you look at a slide as a whole, you may not really pick out. You have to actually get down to small patches and look for certain patterns and then synthesize it upwards. So as an example, we're able to take a slide, grid it into small things and say, these are areas of necrosis and these are areas that are, these are areas of necrosis and these are okay and so on. So this is one example. And we have a couple of more of these things. And now they've given us some new data sets for slightly different biopsies and the problem starts all over again. And this is only one condition, right? Necrosis. There are a library of about 20 pathology conditions, the patterns that they look for. So wide open for anybody interested in this kind of work. The new, slightly different approach, but looking at oral cancer. And can this be done with normal images that can be captured with the mobile phone? Again, Ramesh is leading this, working with some doctors in Raga's Dental College. Very specific problem. They're able to take a photograph and mark it, and now we are supposed to be able to identify similar things. The important thing here is that this can be done in community screening. Somebody said, no, you need at both ends. You need at the diagnostic end when you come to the hospital, and you have to catch early at the community. In fact, this is probably a bigger bang for the buck if it can be done properly. So there's a lot of effort going on these screening devices, screening methods that can actually go out into the field. So it's an important area to work on, and let's see, just very, very early stages of this project. Right?
There are multiple conditions there, but we are talking just about water glucose. Part of it, so we are going to start with that. The requirement is to be able to just take an image and follow.
Yeah, so some of the thing becomes, how can you have a very simple way of data collection that can then scale up in terms of number of people covered and so on.
Actually, we can work very closely.
With whom?
We can work very closely in screening camps where it is done. So maybe we can.
Yeah, we're working with the hospital now, and through them we'll connect.
Yeah. Can take
So none of these problems, I think it should, almost every problem that I'll talk about has been defined or mentioned by some doctor or something, and then we are then working with them to refine into a technology-oriented solution. Right? So this is one kind of data. Another one very interesting type of work is there are also other ways. So NIMHANS has been running these projects for years, which are essentially by the group headed by Dr. Vivek Benegal on how to understand brain development of people in India. Right? There is no easy reference for that. I mean, the few standards. So remember, we all know these child growth charts, height, weight charts. There is no equivalent thing for the brain. So the doctors, specialists have no way of saying, is this okay in terms of size and other factors? The few models that are there are not developed for India. So the CVEDA project, which now leads to the Param project, is essentially about longitudinal study of brain development trajectory. So most of the brain development happens in the first few years and kind of plateaus out and then comes down. By the time you're 25, you started losing matter. And by the time you're my age, you lost a lot of it. So, so they collected a lot of multimodal longitudinal data of cohorts. Sometimes it's 2, 3 for the same person, but they have enough samples of the same age so we can do some aggregates. So they want us to analyze this, and they've given an open invitation to come and look at this data. And we've had a few visits. I mean, of course, once you get into each of it, it's a very challenging problem. So we have to go carefully, but there is lots of data available. And one example of that was what one of our students, Ramesh Naidu, did last year. I think graduated 2 years back. Basically, he was able to take derived data from MRI scans, which give the structural measures the structural part of the brain, the size of various volumes, the curvature, the depth, and so on. And using all these factors, we wanted to see, is this tell us something about the age of the person, right? How do you know? We're kind of trying to get to the problem in a very indirect way. The outcome was very interesting. He was able to show that of course, NIMHANS had data, and they knew these people were healthy subjects and these people were people with addiction. So for healthy subjects, he was able to predict the brain age from the MRI data to within 4 months of accuracy, by and large. And while for people with addiction, it was all over the place. Right? So at least it showed that there is some association, some correlation. We don't have enough data or enough analysis to establish that, but you are able to identify those features of the brain which seem to have developed differently for people with addiction compared to this. Of course, we don't know, nobody knows yet whether the feature caused the addiction or addiction caused the feature change. All we know is there is some connection between these, but this is an early point in that. In parallel, NIMHANS has been doing a lot of work and have come up with normative brain curves for certain parts of the brain. And they're still looking at, so this will help doctors in general be able to screen people and see if, there is something abnormal or something out of whack with this. So, yeah.
Would you be able to discriminate between a normal subject and someone who's addicted or
Not yet,
something?
not yet, right? Because of the variations that are there, the variability that we can't still do a sample of one type of thing, right?
Okay.
It is still saying that there seems to be a difference at the aggregate between people with who don't have any addictions and those who have been identified with addictions. Now, for a given, as I said, the variation can be quite large for an individual, but on an aggregate, it seems to give a. So it's giving the sense that there is such a thing as a normal development versus abnormal development. Now, even with anything, there'll always be, as I say, has to be clinically correlated with other things, right? By itself, it's just one input, but it's a start. So, I mean, NIMHANS doctors see it as a very good start in their idea of building up this thing. This is a long-term ICMR. This is a second round at ICMR funding. It's a multi-site. There are like 8 institutes across the country participating, gathering data from different demographic sections. So it's still in data gathering stage in some sense.
So the accuracy of being able to predict the age within 4 months or whatever, that is when you're told that this person, this is a normal subject.
Yeah. So we all we said is develop this model and said how well does it predict on healthy patients as against not healthy patients. There's a clear difference. Yeah, it's very limited in its scope that way. I'll jump to medical devices, biomedical devices. Most of this is work led by Professor Madhav Rao, and now Dr. Kurian has also joined him. And this is also many years of collaboration with NIMHANS, driven initially, mostly by Dr. Vikas, but there are many other doctors at NIMHANS who also been involved. And some of these, this has been going on for 6 years now, but there are newer versions or newer variants of this coming up. So this is a mechanism coming out of a Sony funding. Essentially, rehabilitative devices for stroke or post-surgery patients, where there are various actuators that are there, which are controllable through an app, and you can basically help people do therapy in a controlled way. Therapy is one of the most important aspects of a stroke recovery or post-surgery recovery. I mean, surgery takes 1 hour, the recovery takes months for many of these things. And it's important to do the right kind of therapy to get full use of your limbs and other things. And, he's been very good working with the students on getting them all published periodically. You'll see 3 or 4 for each of the. And this is an interesting one where not quite in the same thing, but the one is basically using magnetometers and sensors able to detect movement of fingers. And initially, it's also applied to interpreting American Sign Language. So the thing more about was to do flexion of hands in various conditions, but it also has a simple application. And also looking at, we've been working with Dr. Vikas on flexible microscopes for doing dissections of the brain or eventually surgery of the brain. So this was brought to a prototype stage, and then we've not been able to go further beyond because it needs big commercial investments after that. Another class of work, again, all of these feed somewhere into surgical robotics or rehabilitative devices. Those are the 2 broad themes that are there. And this one is about taking a video of, looking at the video of a brain surgery and detecting what are the tools being used and how long they're being used, what are the phases of surgery, and being able to therefore reconstruct the story of how the surgery went, which could be used for assessment, skill gradation, and all those kind of things. Right? So these are, but the idea is also that doing this will give us an idea of how to describe surgery, how to program a robot to do surgery, and so on, because a robot will be able to, need to detect these things and act accordingly. So that's another series of activities. Again, as you can see, they've been published in various places. And this is one of the earlier ones, which actually was a precursor, which was a wearables, which can be used for rehabilitation. Again, you wear this and it helps you flex according to certain pre-programmed mechanism, pre-programmed. And again, for lower limb, for upper limb, and so on. So that is just a very quick idea saying there is a lot of work in the area of medical devices at this level. And we are really, he's looking for more partnerships to build on these things and funding. Okay, so take 10 minutes more than 3, but I'll try to finish by then. So data, devices, and finally the delivery of health. So notice I've not mentioned Tele MANAS till now. There's a lot going on beyond Tele MANAS also. So this is probably where we can contribute easiest from a technology standpoint is basically, okay, let's start with something. So all the healthcare systems that I've been talking about, which, as we mentioned in the beginning, culminated in Tele MANAS, can all fit in that. But maybe start with one slightly different perspective, training. How can we use technology to help train doctors? So think about a doctor. Think about the first real patient they're going to meet. Right? I wouldn't want to be that patient, right? The first real patient. Before that, it's all mocks and stuff. Always think about the first surgery real surgery that a doctor does on his own. So hopefully I'm not that patient, right? So the point is, this is very time-intensive, very resource-intensive to train medical doctors at any level. So there has been a thought that we can use technologies like VR coupled with all the AI techniques to come up with a good training system. And fortunately for us, there was a call for proposals from TIIT Jodhpur, and a whole bunch of us, like Professor Dinesh, Jaya, me, as well as a whole bunch of doctors at Professor Ram, I didn't put it, and a whole bunch of doctors at NIMHANS are very interested in this. And so we have been funded to do this research, basically what's called compassionate communication, right? How does a doctor break bad news to a patient? So you can pick a specific use case and see, and they have to practice this. It doesn't come easily to everybody, right? So the idea here is there's a virtual patient. This is the reverse of what he had done for the interview. So we inverted the thing. There's a virtual patient, and the doctor practices and the patient is programmed to act in different ways. They can be different personalities, different genders, different age, and so on, and different conditions that we can look at. For example, I think the one we took here was taking consent and breaking bad news as our first 2 items. And then they train with that, right? So the doctor says something, we analyze that, and we can trigger behavior of the patient accordingly. And then you have to see how the doctor, so that can be either monitored or it can be self-assessed over time. And you can build in different behaviors into this virtual agent. For instance, the patient can start crying or get angry or just keep quiet. How does the doctor learn to handle these different situations? Now you can think about a real world where this happens. They actually do this by role playing and stuff. You can imagine it's not a scalable thing. This will hopefully be a lot more scalable. So we have taken this as a first step, prototype, whatever you want to call it, and taken this limited. But I believe the framework we are developing, the platform we are developing, will be scalable for other things. So Anirban is also somewhere here, I saw him. Yeah. So Anirban with Dinesh is doing the AI part of it. We are working with Sobin of Hyper Reality here, who's building the VR part of it. And NIMHANS is giving us all the context, the scripts and behaviors needed and so on. We hope we'll get this going or start demonstrating something very soon. So this is a very interesting idea. And this is something that there are probably variations of this in a lot of places. We are looking at it in other places wherever training is a big need in the medical industry. Right? Now back to sort of the more stuff we've been doing for a few years. EMANAS, as I mentioned, is a healthcare data management system for the set up for the government of Karnataka, specifically for the management of mental health data. There is no unique registry of doctors, hospitals, any of those things in India yet. It's all scattered, it's in many places and so on. Ayushman Bharat, the ABDM is trying to do that, but it's still not mandatory. So here there was a Mental Health Care Act that required certain things to be done, essentially registration of mental health, established mental health professionals, and control over the way data was managed and shared and so on. And we essentially, this started back in 2018, it's still going on. It was launched in 2020, but there's always something. So the good news is other states, Maharashtra is in the process of onboarding this. We're making a variant of this for the Central Health Ministry and so on. This was important because it helped us get into the space, understand the thing, and led to some of the other projects that came up. So this is more of a backend system, a hospital information management system that's distributed, covers all, and potentially will cover all the taluka and district hospitals of Karnataka and private establishments, and extend to smaller hospitals if needed. The other end will say, while we have these systems, like I mentioned at the beginning, an important part of healthcare. So turns out that severe mental health is also a chronic condition, needs ongoing care, needs screening, needs identification, needs ongoing care. And so we're working on a project with NIMHANS called NAMAN, which is essentially a community-based program where essentially community health workers go up to the patient's houses, screen for using questionnaires, follow up with them, and that data all needs to come back to the doctors. And they have to manage the flow of patients. You know, somebody has to go, come back for a follow-up. If that gets dropped, the whole chain gets broken, the whole chain of treatment gets broken, and it's not as effective. So this is a pilot project to see, the pilot in the sense they're going to do it in two districts, one in Karnataka, one in Uttarakhand, and we're going to see how that goes, right? We had earlier done a project called Shema, which was similar, but in a very slightly different way. And actually, both of us are learning from it and building onto this thing. Of course, it's not just a question of building an app. You have to make it, because these are going to be community health workers that are going to go out into the field. Network is always a problem. Whatever you might think of, there is not that good coverage everywhere. So you're going to have to make systems that work with poor network connectivity, and the data remains consistent, integral, synchronized, and so on. And there's a lot of sensitive data sitting on those tablets, so privacy and security issues around that have to be thought through. And he has to make it in every village of the country, every nook and corner. We'll make that part of it. We'll write a proposal to say we'll also provide one 5G box with every tablet. You can carry it with you. Please make a pitch to the health department. And of course, Tele MANAS you talked about, it's a national tele-counselling helpline, now operational throughout India. Every state, every union territory is covered. There are 53 cells, as they're called, set up. You can see all these red dots. And each of them has a bunch of trained counselors. The part we have done is to help set up the software so that when a call is made to a single number, 14416, please all remember that number and propagate it everywhere. You make a call, it gets routed to the cell in your area. There you will have counselors who are trained in the local language who will be able to provide counseling. What we are doing is providing them an application, a software where if the patient, where they can enter the complaints, comments about the patient. And if the person were to call again, which we are noting a lot of people call many times, the history of the patient is easily available. That is critical for success. In fact, on the first day, the first thing that was mentioned is we need some way in which the history of the patient is available, otherwise counseling is a waste. Because they spend half an hour, 45 minutes in the counseling. Next time they talk to somebody else, nobody wants to repeat their life story and so on, right? So that turns out, and that brings up with its own challenges of security, privacy, performance, that we.
Thanks to your national user,
Oh, okay, good. So NIMHANS has been pushing them, saying you need to do more advertising. Right? Yeah, in fact, they've asked for more budget this year to increase. Yes. For privacy reasons, right now it was decided in the first phase we will not record. We will not record the voice. There's too many issues that come up if that happens, and that might come up in a later phase. We're still at an early stage, I would say.
No, that's not what I was saying. You will not record voice, but you could still kind of do a speech to text and have some automated summary instead of relying on the person who may or may not fully understand what is being spoken. Because there's a lot of repetition, there's a lot of hesitation. And so you are relying on the person to transcribe it correctly. Are they trained to?
Yeah. So these are trained counselors. They go through a rigorous training program that's run by NIMHANS. And they have a protocol in place to make sure they're certified and all that. But yes, your point is, we also thought about a lot of these things, but there is so much just getting this operational and used everywhere. So this is all seen as, so the ministry keeps asking us, when are you going to bring AI into this? And we want to do it a little slowly, right? So there are some things we're looking at which are, for instance, if a person calls 10, 20 times, there is something, but for the counselor, while they're talking, to read all those 10, 20. So we're looking at a summarizing mechanism that can, so Dr. Tulika is starting to work on that as an example, right? there are training type things we can do where we are trying to look at how we can. So I think without directly impeding the main process, look at supportive things that will improve the efficiency of the process. And at the national level, basically we work with the ministry. NIMHANS is the apex body. We are responsible for the IT architecture, as they call it, and there's an entity called NHSRC which looks at how many doctors, how are they, are they spread out and all this kind of stuff. Going well, a lot of work to do. Never a dull moment in this. So, so the idea is that while now we are focusing on the voice calls, we are just in the process of adding video consultation. So we'll have an app or other process where you can. Because of the nature of the counseling, they want it to always be an audio call first, and the doctor, the psychiatrist, if this will decide if this video call would be appropriate, and then we'll be able to upgrade the call to video like you might do in a WhatsApp call, right? That's what we're working on right now. By October, it should be launched. Yes. And then people will also go and visit in person. So all the data has to be integrated. So that's the other part, and in the back end, integrating with ABDM and things. So this data management is a big part of this thing. No, I said they are the guys who want to implement it. So. Ongoing. So I'm just reminding them of the deadline. And so, like I said, privacy has been, so there's been a lot of work on more on the research side on health data privacy. What does it make in a, so we have essentially no, right now there is no standards here because it is just structured data, semi-structured data. We are not using the diagnosis when the doctor does it uses ICD-10 or 11, right? They're not ready for SNOMED yet. ICD is what's largely used in the public health. Though SNOMED is the standard. So basically, we are looking at the question of how to design applications that are distributed in nature, because even though hospitals may have different applications, the data is all connected and all that. How do we maintain privacy and ensure consent of the patient? And this was a PhD for Swapnil, not here, but who just submitted a thesis a few months back. Deepa Austin, who was a PhD student here, has been working with Professor Amit on looking at understanding the malnutrition management. How are children with malnutrition treated? And there's a whole elaborate setup for that, starting with specialized hospitals where these babies or children are admitted, they go through a treatment, and then they are sent back to their homes, and they're expected to be taken care of at the Anganwadis and the local things. But because no information passes very well, or the chain keeps getting broken. So she looked at that whole problem and designing something that will connect the Anganwadis, primary health centers, and the NRCs in the hospitals to manage this problem. So for each problem, there's a peculiar set of problems. In each disease or condition, there's a peculiar set of problems. And the outcome was we worked with a C-Step, another company, to actually develop some apps. She spent a lot of time working with the doctors, with the Anganwadis, to understand exactly what would make this work, and designed it and got operationalized. But I think COVID came and kind of things haven't moved much after that. It's still there. I think to some extent it's being used. So this led to a PhD thesis. That's one good thing. And she's also, studied it from the complexity theory standpoint, saying why are these healthcare systems so complex and what you should kind of keep in mind when trying to design solutions for these, which are not just the technology alone. And working with the doctors at Bangalore Medical College, they've been able to come up with policy recommendations that goes into this. And she also came up as part of this, the diet quality questionnaire, which has been copyrighted and can be used. And I think now they are looking at, just to extend in a different direction, looking at ethical assessment for the IoT and AI in health, and essentially looking at tech ethics and practice. Okay. Last two slides. So there are lots of different things. So the other part on all this is, again, coming back to mental health, a lot of people suffer from or have what are called common mental health conditions, not severe thing, doesn't need medication stuff, but needs counseling, therapy, and so on. And this is really the realm of clinical psychologists as against psychiatrists. So we've been working with clinical psychologists at NIMHANS, led by Dr. Seema Mehrotra. Since they're one of the, probably the first person I started working with there. And we worked with them to develop a whole, so they have some ideas, they have some idea of how this therapy should be done. And we worked with them to help design apps, websites, whatever, and actually build and deploy it and test it out. And it's been going very well. And we actually over time managed to get funding from Microsoft Philanthropies, who've given NIMHANS a whole bunch of money, some of which we get to do the development. ICMR now, she's actually proposed and got 2 ICMR projects, one specifically aimed at improving student well-being, the other one looking at digital applications, interventions in general across multiple sites. And we are the technology partner in all of them. Right? And so essentially over this time, a whole bunch of apps have been developed, started with PushD, which is a depression therapy app. It basically walks the patient through the kind of things they would do in a face-to-face interaction, which would require them to come and see the doctor every week or every month, depending on where we are. These are based on cognitive behavior therapy and other things. And what we have done is put that in a form of an app, a guided app. It's like a course you have to do in a very structured way. And the data is monitored by the therapist so that they can intervene if needed. Mind Notes, on the other hand, is again, helping people understand about mental health and encouraging them to seek help if they seem to satisfy. So what's called breaking barriers to seeking help. That's the theme of this thing. We are now, these are all just, I would say, apps and websites. There's a lot of work, but maybe not very complex technology, but very subtle things that have to be done. We have now developed, designed, actually at COVID time we had done this. We wanted quickly a forum where healthcare workers could communicate with each other to seek support. And that's kind of been generalized, and we have set a forum, online forum, where somebody can post a question about mental health, and trained volunteers will respond, moderated by a clinical psychologist or a specialist. And we are just in the process of launching as part of the ICMR project, specifically focused on student well-being. So a whole bunch of resources and other things that this is a major problem that's been identified by ICMR, and it's mostly going to be informational initially, and some other things. So there is a range of these things that come on. So these are attempts to use technology to get therapy, help, whatever, in the hands of the patients, rather than them having to come to clinics, which they won't. Right? So each of these, I chose the set of projects because each illustrates a different part of the healthcare puzzle, and you can play in any one of them or all of them. Right? There's so many different ways in which technology can be. So with that, that's a little over time, but thank you. Any questions? There are a few more projects, but I thought this would give the flavor of the range of things going on and the breadth and to some extent the depth of work that's going on. Huh?
I want to know more about it than what I knew when I talked to you. Thank you.
Welcome. Typically, we talk about any one of these projects, but each of them has some interest, and they all kind of connect to each other somewhere. Of course, the doctors in NIMHANS said, you've done all these, are they all integrated? Can you do this? And I said, there's still some distance.
What do you call, most of these rural centers where district headquarters are all connected, supposed to be connected by fiber optics, right? There is a bandwidth there. So we can think about a mechanism of certain kilometer radius across that, which can be covered using some 5G network or private 5G space. We can actually put a box there in each of the locations and then cover the rest on. So we can do that.
We need to have a good conversation, come up with a good proposal.
Yeah, actually, I will, one of these bottleneck in Tele MANAS, I'll tell you. I'll give you an example first, then I'll tell you the problem. There is a pipe, big, 1 feet radius pipe, okay? But if I leave water there is a very little, then there is no use of such a big. So we have fiber till the end to village, but the bandwidth allocated by the BSNL or XYZ is very low. So they tap has to be opened, the bandwidth tap. So that needs money. Okay, that has to be jointly done by the proposal. So pipe is there, tap is there, everything is there. Yeah. Yeah. So if that can be done, I'm telling you, what you are asking, it is done already. That is a huge project called NII 2.0 BharatNet, whatever it may, 72,000 crores of rupees spent to lay down fiber. Everything is done. Only this has to be done with respect to the project with him for the not tele MANAS, any telehealth.
One district. Okay, we'll talk.
Yeah.
We'll talk.
We'll talk. Thank you. But I'm telling you, solution is there.
I have one question.
Please.
Uh, so all these technologies or interventions seem to be directed from, I don't want to call it top down, but it is like improving the system so that it helps people. I was wondering if there are interventions which could be designed to increase the some sort of empowerment, not empowerment in terms of what is that called, awareness and stuff like that. Would that have an impact on the expensiveness of the healthcare system? Because I will give you a case in point. Most of us have been to Narayana, right? You have seen the third language there. The third language is not Kannada, it's Bengali.
Bengali. Many hospitals.
Okay, it's Bengali. The reason is that lakhs of people from Bengal, I don't know whether it is true or not. I don't think it can be that true, but most of those people think that West Bengal healthcare system is bekar, and if I want to live another day, then we have to come here. Right. So the question is, so this is an example of very low awareness and people suddenly becoming very panicky and traveling all the way from Bengal to Bangalore, overcrowding here, and everything gets impacted. So that's one example. Could something be done to avoid this situation?
I'm sure, yes, right? But then, see, the other tricky part here is who is going to do that? In India, health is a state subject. So it's the operation, the public health is run by individual state government. Each has their own style and focus and so on. So it's very difficult to coordinate all of these and have something. So in this case, the best would be for that government to raise awareness, or some NGO or some private body to do that. Yes, it can be done, but somebody has to take that up and work on that, right? Awareness is not an easy problem. I mean, for instance, now I think everybody should know about Tele MANAS, but 9 out of 10 people I meet haven't heard of it, irrespective of their social demographic classes. So it's a complex thing. Yeah, it's there, but never thought. So the approach we have taken, and definitely what I have taken is, these are experts who are telling us they need this help. Can we do something to improve that, right? And in that process, try to, for instance, healthcare workers in the field, when you design it, we talk to them and try to understand what they really need and make it useful for them. So as Amit keeps pointing out, we don't want a system that's just going to collect data and report at the end of it and penalize them. Can it actually make their job better? Right? So whatever, they have a very complex set of activities to do. Can this app help them manage that better so that they do what they're doing well, right? So less paperwork, easier way to find information, reminders, all kinds of things. So we do try to design it in a way that makes sense for the persons using it. That's the best. Okay. The original statement was build an app that they'll enter data, it'll show up here. That's how it starts. But then as you go through the project, you bring in other perspectives. I think same thing was done in the NIRC, the malnutrition app and so on.
There are no more questions. We can close this session. Thanks, Professor Srikanth, for a very immersive and engaging talk. Okay. I think Professor Das sir keeps, his vision is about doing translational research. This is a classic case study for translation research at a scale. And I'm so proud to say that my observation is that very few universities are picking up research and doing innovation or doing national level programs. And IIIT-B is leading this. I think there are many more to be done. We should be proud of all of this. Thanks again, Professor. And thanks for all the attendance.
Yeah, thank you all. And as always, an open invitation to join the bandwagon and try to find problems to work on. There's no shortage of problems. There are plenty of cooperative, collaborative doctors and administrators. Funds are available if you put our mind to it. So we can make it happen. Thank you.